All right, well, we'll go ahead and get started. Thank you so much to everybody for being a part of our UIC summer series. I'm Ryan Wynn. I'm one of the assistant professors. I see patients who have thoracic and skin malignancies over at UIC, and I'm also the director of our precision oncology program. I really want to thank all of our sponsors for helping make this program possible, to our planning committee who has worked tirelessly to put this event on. This is the second installment of our series. We did the first one in winter. This is the second one that we're doing. We're hoping to make this a bigger and bigger event as time goes on. So we appreciate our sponsors, and please let folks in the community know about this as time goes on. And also want to shout out all of our attendees who are on this virtually as well, because I know there's some who couldn't be here in person. I wanted to let everybody know a couple of housekeeping things. Please take the pre-test questions. So there are QR codes that will intermittently display on the slides, as well as at the check-in desk. Make sure you're doing those pre-test questions as well as post-tests so you can claim your credit for CME. With that, I'd like to go ahead and introduce our chair for the day. So Dr. Abiola Ibrahim is an assistant professor over at the University of Illinois in Chicago with me. I'm very fortunate to call her a work colleague and a friend. She is internationally renowned for her work in breast cancer as well as in global clinical trials. She's also vice president of Aortic, which is the Oncology Association of Africa, and she is doing some really groundbreaking work in trying to bring clinical trials to that space of the world. So with that, without further ado, I'd like to introduce Dr. Ibrahim.
Thank you for that elaborate introduction. And thank you and welcome everyone for joining us today. Today is June 10th, and thank you for spending your time with us instead of in the sun or on the lake. So we will make it worth your while. Not only will we be learning, we will at some point during the break kind of imagine together a kind of a therapeutic session where we'll be on the beach together and celebrating our Juneteenth holiday. All right, my name is Abiola Ibrahim. I'm a breast medical oncologist. I'm also the community outreach engagement liaison with the Trans Oncology Program, and clinical trials is dear to my heart. Clinical trial diversity, which regards to minority patients, especially Black patients like myself, and that's why I'm at UIC in Chicago here doing what I love. So that is to say, if you do what you love, you will never work a day in your life. So I'm still looking for a job. All right. So I would quickly talk about the ASCO 2024. Will I say updates? Or probably interesting stuff, right? There were things that were good. And I feel like this is, not that I feel, I know that this is going to be the direction of our practice. We start talking about those things and then the practice changes. So the question is, antibody drug conjugate as neoadjuvant therapy, right? And one of the abstracts that was presented that I found interesting was that I-SPY 2.2 actually showed they wanted to assess the rate of pathologic complete response after neoadjuvant of the ADC therapy, daptomab deruxtecan, that's DATO. So they wanted to give this agent alone, and they wanted to see if the patients were going to achieve PCR. And if they did achieve PCR, they were going to go to the next phase. And that's the beauty of I-SPY. The I-SPY consortium have the ability to look at this novel therapies to see that are they functional and can they move to the next step, instead of us having all these long trials spanning decades before we have an answer. Well, and they chose this agent, single therapy agent in the neoadjuvant space, and they picked this tumor with respect to DNA repair deficiency, luminal signatures, whether they had hormone receptor disease yet or no, and they classified them into S1, S2, S3, S4. The summary of the study was to show that this agent, as a single agent neoadjuvant therapy, actually did fail. So it did not move forward. So I think we will not be hearing about this in a while. Then the next thing I found interesting was the Mama Print Index and 3-year outcome of patients with high-risk hormone receptor positive breast cancer patients. So what this study did was it was a prospective study enrolling over 600 patients in it with stage 1 to 3 mama print high risk, blueprint luminal B into the cohort. So they classify them as having either high risk 1 or high risk 2. As it is in practice right now, we want to know if the patient is high risk, mama print low risk, or mama print high risk. If the patient was high risk, we give chemotherapy. Then we start figuring out what kind of chemotherapy are we going to give this patient. Now, this study was able to answer the question that, okay, can we predict the type of chemotherapy that these patients are going to receive? So they looked at ACT versus TC in these patients, and they grouped them into high risk versus high risk 1 versus high risk 2. So what they found out was that in the high risk 1 patient, right, ACT treatment treated tumors had no significant difference. But in the high risk 2 patient, which was about 15% of the patient or thereabout, TC actually did worse. So what they concluded was that, well, not only did MammaPrint have a predictive or prognostic value in determining who gets chemotherapy, yes or no, they are beginning to be able to predict the kind of chemotherapy choice that we're going to be using in this group of patients. All right, so the next update was we looked at an update of the Netele study, which already we know that this has already showed is statistically significant invasive disease-free survival. And also we do know that they have a distant disease-free survival. So the update in ASCO actually did show that they still continue to have consistent efficacy benefit, and their side effect was very manageable. All right, so the next update event in ASCO 2024 was also, there was this question in hormone receptor positive patients who had ER low, meaning they had 1 to 10% of hormone endocrine positive on IHC. The question has always been, are these people really truly hormone receptor positive disease? Do we really need to give them adjuvant hormone therapy like we always did? So this was a prospective study that enrolled over 350,000 patients in it. And majority of these patients, as we practice, they always received chemotherapy. And then we wanted to see if this patient could actually omit hormonal therapy in this group. And we did see that if we did hormonal therapy, the patient that omitted adjuvant endocrine therapy had worse survival outcome, not even distant disease, worse survival outcome. So what this means is that we are going to retain this practice, and we will continue to give patients adjuvant hormonal therapy, especially if they tolerate it. All right, so moving on to our practice, what we are still doing that is not changing yet, is we'll talk about hormone receptor positive disease, triple negative, and HER2 positive disease. All right, so this is a couple of questions that when I think about it, I would read it out, and then the question is, what are we going to do? 59-year-old postmenopausal patient with hormone receptor positive disease, T1, N1, and a recurrence score of 25. What would you recommend? Is this a patient that you want to add adjuvant chemotherapy to their treatment, or you just want to give hormone therapy alone? So again, if we change it from an N1 disease, if it became an N2 disease, the same recurrence score, what are we interested in doing in this patient? Are we going to do add chemotherapy to the treatment, or are we going to continue with hormone therapy alone? Again, if this patient, same about the same group, two things have changed. Now, instead of being menopausal, they are premenopausal, and the recurrence score, instead of being 25, it's like 15 now. Again, what are we going to do? Is this the same AI alone or adjuvant, in addition to adjuvant chemotherapy? So the rationale for chemotherapy really in this disease group has been based on TAILORx, RX recurrence survival data, and the MIDA trial and the RX Panda trial. So I'm just going to talk about these two pivotal trials, studies, and while we justify what we are doing, and some new updates and nuances towards the end. All right, so we all know this data. We also know that in this group of patients, with the RS 11 to 25, when we compared endocrine therapy versus chemoendocrine therapy, we did see that in all comers, there was really no difference in invasive disease free survival. Neither was there any difference in the freedom from recurrence at the distant site. So what we did see again is that in this group of patient recurrence score 11 to 25, the benefits of chemotherapy was found in women 50 years or younger with that recurrence score. And when you look at this according to menopausal status or age, I mean, you expect that when you're 50 years or less, or if you're premenopausal, you're expected to do better. I mean, not that you're expecting. We see that they do better with chemotherapy. And we also saw that when this was updated like 2 years ago, it still continues to hold, and we see that it's even improving, and it's a stronger data to show that in this group of patients with premenopausal young women, they are more likely to do better when we add chemotherapy. So what we see and what Telerex did tell us, because it looked at patients that had node negative disease. And what I do in my practice is that when a patient is postmenopausal with node negative disease and they have a recurrence score less than 25, I'm more likely not to give them chemotherapy. And then I use mama print, so mama print, in as much as this mama print and Telerex is not interchangeable. Last year I went on this long discussion about the how we use mama print and oncotype DX, and how you can, when you have those results, or if you have oncotype DX, and how you can interpret it to mama print. I'm not talking about it today, but the only thing I'll just say is that they are not interchangeable tests. And I prefer mama print because it's been shown to do better, to be much more predictive in Black patients, and especially younger patients. But for the purpose of the summary of the Telerex trial, especially in the which was done in node negative patients, what we did see was that in premenopausal women there was some benefits with chemotherapy. So our exponder is a that was looking at patients with positive node and in this same group of patients. And again, this is an kind of oldish. This is 2 years ago, almost oldish kind of. So we see that again, premenopausal patients were more likely to benefit when you add chemotherapy to their treatment compared to postmenopausal patients. So when you look at this group of patients, according to their disease status, whether it's postmenopausal or premenopausal, you see that the invasive disease-free survival is really different depending on post or premenopausal. So the question now is it the same hormone receptor disease in this group of patients? Does menopausal status actually make it a different disease entity, And the same thing, and we have a trial, offset trial, that is looking at this question: that is it the addition of ovarian suppression that patients get when they get chemotherapy that is actually in giving us this improved outcome? Or is it that it's a different disease? Is it different tumor biology because you're premenopausal or postmenopausal? Is there a difference? So the jury is still out there, and we are still thinking about this in our clinics or in the bench world. All right. So we do know, what about the hormonal therapy in low risk patients? For postmenopausal patients, of course, they will get AIs. What about premenopausal patients? In my practice, because of the updates of soft and text trial, which showed that ovarian suppression in this group of young premenopausal patients is of benefit. So I'm more likely to do ovarian suppression plus tamoxifen. Sometimes I start with ovarian suppression and AIs. right? I try to cajole them for like the first 5 months for them to get it. It's not a very easy therapy to tolerate. And then I can kind of relax to like ovarian suppression with tamoxifen, and then tamoxifen is my last bet for premenopausal patients. And my target is if I can keep them on ovarian suppression for at least the first 1 to 2 years, and then we can go ahead to do tamoxifen for this group of young women. So what about the role of neoadjuvant therapy in hormone receptor positive breast cancer patients? So neoadjuvant or endocrine therapy doesn't do well. Endocrine therapy doesn't even do well in the neoadjuvant space, right? The only time I use that is for patients that don't want to do surgery, or patients that are elderly, or patients that we are delaying the surgery for some comorbid reason. Then I put them on hormonal therapy, and you need it to be for them to be on it for as long as 6 months to even see some reasonable response. PCR in these patients is probably less than 5. I've never seen it before. So it's textbook reported. So what about neoadjuvant chemotherapy in this group of patients? Again, we've used neoadjuvant chemotherapy in patients that have high risk of relapse, meaning that they have later stages and they have ER low. ER low patients, in as much as we now have data to show that they benefit from endocrine therapy. But sometimes we think that these patients kind of behave like triple negative breast cancer, especially when their Ki-67 is really very, very high. All right, so we see the role of immunotherapy in this group of patients. The keynote 756 that was discussed last year. And we see that in this group of patients, there was actually PCR better than just endocrine therapy alone, and even much more better when you do add chemotherapy. So in comparison of this group of patients with chemotherapy plus immunotherapy, it did much, much better than just chemotherapy alone. And even as such, we are celebrating a 30% PCR in this group of patients. So you see that this group of patients don't really do well in general in neoadjuvant compared to when you're looking at HER2 disease or triple negative, where you see that their PCR is much, much higher. All right, so what about adjuvant therapy after you've done surgery, you've done, and then they come back to clinic, and then we want to give them endocrine therapy? Then the question is there any role for adjuvant CDK4/6 inhibitors in this group of patients? And the Monarchy and the Natalia trial showed us this. And like I initially said, Natalia trial's updates this year is that it's consistent. The benefits is consistent, the efficacy benefits is consistent, and the side effect profile is actually it's very tolerable. And if you use abemaciclib in your practice, you'll see that the side effect is so intolerable to our patients. All right, so talking about intolerable side effects, which I know the metastatic presenter is going to be talking about, breast cancer presenter is going to be talking about. One of the ways I try to adjust abemaciclib in the clinic is to kind of use graded therapy instead of giving the 150 milligram twice a day. You just have to start from 50 and start going up before the patient can reach the maximum tolerant dose. Again, the Monarchy trial did show IDFS and DFS was seen in that group, and the same thing with the Natalia trial. Like I said initially, the ASCO update this year was that the efficacy benefit is still present and the side effect is tolerable. And me just comparing in clinic, I would prefer Ribo to abemaciclib just because of the diarrhea side effects. But my patients, I mean, again, some patients prefer abemaciclib, some prefer this because they just want to be consistent on the drug. They don't want to stop back and forth. So again, it's more patient directed. All right. So what about BRCA mutation and this disease? The Olympia trial actually it was a huge trial which looked at triple negative breast cancer patients and hormone receptor breast cancer patients. And after receiving either you get a neoadjuvant treatment, surgery, and then whether you get adjuvant treatment or radiotherapy, once they are done with the treatment, then they randomize them to either get PAP inhibitor, that's olaparib, for a year versus placebo for a year. So this patient was followed, and for 10 years. And what the results showed really was that in triple negative breast cancer, which we'll talk about, the result was very profound. And in addition to that, we also see benefits in hormone receptor positive breast cancer too. So we do know that in this group, in high-risk patients, when we say high risk, that is like high-risk stage 3, 2, 3, node positive disease, Ki67 high, and then even if they do have BRCA mutation, we have treatment for them more than chemotherapy and more than endocrine therapy. And these are patients that you might be able to put on PARP inhibitors and what have you. All right, so triple negative breast cancer. How am I doing on time? Let me see. Okay, I think I'm good with time. So for the triple negative breast cancer to we look at the tumor biology of these patients before we start thinking about treatment. For this group of patients, we have more of chemotherapy, chemotherapy, chemotherapy. But now we are kind of moving towards targeted therapy, as in we have been successful with the use of immunotherapy. So neoadjuvant chemo immunotherapy keynote 522, where we actually did see patients with stage 1 to 3, and then these patients were enrolled either to get chemotherapy with pembro or chemotherapy with placebo, and then neoadjuvantly, and then they looked at the PCR, then they did surgery, then looked at the PCR, and then they continued pembro versus placebo. So what we see with this study is that in this group of patients, we did see a huge PCR in the patient that received chemoimmunotherapy. And just for comparison's sake, you see the patients that just got chemotherapy alone, right? Without immunotherapy, they are on 51%. You can compare them with endocrine therapy with what, 20%. So endocrine therapy, I think the thing of, I don't know. I'm not sure that disease does well with anything neoadjuvant. Back to triple negative. I always digress when I talk back and forth. So, so what we saw with the keynote 522 was that in neoadjuvant space, pembro actually did well with the PCR, and even though as far as we don't have an overall survival benefit yet, but we do know that these patients actually do well in all comers. Then what about the chemo immunotherapy in triple negative breast cancer without anthracyclines? The question is, can we actually do without anthracyclines in this group of patients? Because we do know that anthracycline is the backbone of triple negative breast cancer. Can we do without it? All right. So, I think we know the answer to this before we start talking about the data. We do know that in this disease, we see that this shows a positive PCR in this group of patients. And then that is to say, after we've already treated this patient and then we're done, and then the question is, does capecitabine from the CREATE X trial have benefits in adjuvant treatment after this group of patients? So, and the answer is yes, right? So when you look at the disease-free survival in this group of patients, looking at capecitabine versus control or the DFSS, and then there was no strong overall survival data in this group of patients. All right, so I've already talked about this. So again, in the PARP inhibitor world, patients that had triple negative breast cancer with BRCA mutation, will they do well when we add PARP inhibitor with their treatment? And of course, we do know that they actually not only have benefits in invasive disease, they also have an overall survival in this group of patients, actually. That this is not updated. There's actually an overall survival. All right, so moving on to HER2 breast cancer, I'm going to be looking at this with the very low risk, and high risk patients. And the definition of very low risk is patients with T1AB, that is less than 10 millimeter, no nodal involvement, pretty much stage 1. So when you look at NCCN guidelines, they suggest whether you do treatment, whether you give treatment, yes or no. They're neither here nor there. So what is the data behind this? A meta-analysis was done, and it was published, I think, last year or 2 years ago. And what it looked at the benefit of trastuzumab in this group of patients. And it looked at 12 studies, and the overall patients was about 7,000. And what it did show was that the absolute increased benefit of trastuzumab over no trastuzumab was 7% at 5-year disease-free survival, and there was no overall survival benefit. So this is a group of patients that I actually do use. I mean, it's a discussion between myself and the patient. If the patient doesn't want it, I'm fine with it. And we can just go into surgery, of course. But this group of patients, it's more of adjuvant treatment, nothing new adjuvant. It's adjuvant trastuzumab. So the next question is, what about low-risk HER2 positive disease? Low-risk HER2 positive disease is a patient with T1C between 1 to 2 centimeters. Again, a meta-analysis was done to look at the benefit of trastuzumab in this group of patients. And the benefit, meaning the benefit of adjuvant trastuzumab in this group of patients. And it looked at 5 studies, and over 4,000 patients were in those studies joined together. And what we did see was that there was 17.3% versus 2.3% benefit of trastuzumab for disease-free survival. And there was a profound overall survival of 7.8% versus 11.6%. So for this group of patients, for sure, you have to give trastuzumab, and there's a profound effect on that. All right. So what about the escalation of therapy in this group of patients? So meaning that can we get away with the less chemotherapy in this group of patients, right? Can we just get away with just giving paclitaxel and trastuzumab as adjuvant? So yes, the adjuvant paclitaxel trastuzumab trial, the APT trial, looked into this, and they did enroll over 400 patients in this, and the patients had HER2 disease alone. It could be either hormone or hormone positive or negative, definitely node negative disease. And they enrolled them to get 12 weeks of paclitaxel trastuzumab, and then after that, followed by a year of trastuzumab. And what they wanted to see is that what is the treatment of this as far as 5% rate of recurrence after 3 years. And what we did see is that the overall survival of this group was about 95%, and the disease-free survival was 93.3%. So the 10-year breast cancer specific survival was 98.8%. So what that means is that with only paclitaxel and just single agent trastuzumab in this group of patients, it's actually beneficial. So less is more, really. So it's more about speaking into this de-escalation of treatment in this patient group. So what about TDM1 as adjuvant therapy? That's the ATTEMPT trial, right? What about the group of patients that want to just TDM1 and nothing else, right? So what they did was they randomized 3-to-1 patients to receive TDM1 for 17 cycles versus trastuzumab and TH and paclitaxel and trastuzumab, and they looked at over almost 500 patients, and what the objective was to compare toxicity and to evaluate invasive disease-free survival. And what we did see is that there was a 3-year advantage in invasive disease-free survival, about 4.4, benefiting the TDM1, but there was no difference in quality of life. As a matter of fact, the TDM1 was less tolerated. Patients in the TDM1 group actually failed. Most of them discontinued their treatment, and they just couldn't tolerate the treatment. So the only benefit of this TDM1 is that if patients want to avoid alopecia, neuropathy, maybe this is the treatment for them, right? But other than that, I would want to use the paclitaxel-based treatment. So what about the high-risk breast cancer patients? So high-risk breast cancer patients, that is the stage 2 to 3C patient. In this group of patients, I'm more likely to use neoadjuvant therapy because I want to see how this patient would react to treatment. And in this group of patients, we are more likely to use dual HER2 therapy. We we've had enough successes in this group of patients. The PATRA trials and ETC have shown that this Neosphere trial and all that has shown that the use of the benefits of dual anti-HER2 therapy. All right. So Fergen trial, this is the Lancet publication, showed that can we de-escalate chemotherapy in this stage 2 and to 3? How many of them actually benefit from HER2 treatment, right? They can't be just one. They can't be one size fits all. It can't be just heterogeneous. So let us see who is going to benefit. So the eligibility criteria for this study was, again, stage 1 to 3A patients, and they used PET scan. They will before they get on the study, they enroll them on the study, do a PET scan to make sure they don't have any metastatic disease, and then they enrolled them to the study. So let me go back. So the first group, is there a pointer here? There's no pointer. Okay. So the first group, once they get enrolled, the first group is going to get TCH, P, and then the second group gets just PH, meaning there's no chemotherapy. First group gets chemotherapy backbone, the normal chemotherapy backbone, and 2 anti-HER2 therapy. The second group, which is group B, just gets the 2 anti-HER2 therapy. Question is, can we do without chemotherapy in this group of patients? Now, after we've given the 3 cycles of treatment in this group of patients, then we get PET scan. So they do the PET scan. I mean, they give 2 cycles, then they get PET scan. After the PET scan, they determine if the patient has no response, we go back to what they should be getting. If the patient has a response, they continue. They continue to complete 6 cycles, then they get surgery, and then the result. So like what I said, so PETs, after 2 cycles, you do a PET scan. If this group of patients that were on the just the HER2 therapy without chemotherapy, if they responded, will continue to complete 6 cycles of anti-HER2 therapy, then surgery. If they didn't respond, then we'll move them back to complete 6 cycles of chemotherapy plus anti-HER2 therapy, then surgery. So what we actually, they do surgery, then we do a PCR, and look, the ones that had PCR completed, they will give them just 10 cycles of anti-HER2 therapy, and those people that did not have complete PCR, we can change treatment or continue with that. So what they found out is that we looked at the PET responders and the non-PET responders. 20% of patients actually were PET non-responders, while about almost 80% responded to PET. You know, it's a very expensive study, really, because no insurance is going to approve this. I'm just saying. For you to get an insurance to even get PETs, it's going to be a nightmare. So, so what we did see is that the 3-year invasive disease-free survival rate was 95.4%, and the secondary primary endpoint was met in this group of patients. Pretty much what we're trying to look at in this patient is that what group of patients can actually do without chemotherapy. And in this group B that went all the way, about 20% of those people went all the way and did not need chemotherapy. They are still holding, right? They don't have any disease recurrence. So what that means is that in that high risk HER2 positive patient, they are not the same. Not everybody needs chemotherapy. Now, how do we know who? I'm sure it's not PET scan is not the answer with which we can determine what. So that is still up. So conclusion about a group of patients can actually omit chemotherapy. And I'm sure PET scan is not the answer. We have to look for something else to find out that. But this is where the breast cancer treatment in this group of patients is going to. All right. So what about adjuvant treatment? We know that dual anti-HER2 therapy is what we give these patients, especially if they have complete PCR. And then we have the update of the Caitlin study, which looked at anthracycline-based treatment with HP, which is pertuzumab and trastuzumab, or instead of giving that, you give them TDM1. Again, we did not see any benefit in the group of this TDM1 patients. All right, so still talking about it to directed therapy. If a patient did have residual disease after neoadjuvant treatment, what do we do? The Catherine trial already told us that in this group of patients, you can actually do TDM1. And then for patients that have hormone receptor positive disease, what do? We can extend with neratinib because it's been beneficial from the XNet trial. So adjuvant biphosphonate, again, risk of reduction of distant metastasis. This is actually my last slide. And we see that in this group of patients, we give them, even in the early stage breast cancer, they actually do benefit from the use of adjuvant biphosphonate. And thank you for listening. So any questions? I know it's a very old study. It's very, very old. I know there's for adjuvant what biphosphonate? Yeah. Yes. Yes, 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 yes.
One question as well. So, thank you so much for the great talk. For those patients who are HR positive, it seems like there's a lot of options. So, how do you kind of discuss the patients at the beginning? You know, you could do chemoimmunotherapy and then neoadjuvantly, you could do C4, 6 adjuvantly. If you're BRCA positive, you have the olaparib offset. How do you kind of have that discussion with patients about making it work?
So one thing I do in my practice is I want to get a feel of what the patient's life is because it's just early stage breast cancer, right? Tops 5, 6 years, you're done from my clinic. If you have high blood pressure, you'll be seeing your high blood pressure doctor forever or something like that. So how do I get you out of my clinic? What is your quality of life is? What is important to you? Do you have something that you want your hair to grow? Right? You want to show off your hair. Are you okay with wigs? What do you want to be in the clinic with a port? Right? Or are you okay with coming here for the extended treatments, and all those stuff? So once I get a feel because of their quality of life, then with the tumor biology, we have an extensive discussion. And with the age of the patient, if the patient is young, premenopausal, I want to send the patient to endocrine, fertility testing, and maybe store their eggs. And if the patient is postmenopausal, because it depends on the tumor biology, the quality of life of the patient, and we will have a joint discussion on what to do. Yeah, absolutely. So I give them the side effect. Believe it or not, I have patients when I tell them you will have diarrhea, they tell me, give me the 150 dose. I want to lose weight. I kid you not. Right. And they do lose weight, and they tell you, well, I don't have to use all this diet tea. Now I have my abamacycline. So now we start going back and forth on I'm gonna have to reduce your dose. Yeah, I don't want you losing so much weight drastically, right? Some of them are okay with 2 years, some of them are okay with 3 years. Again, it's the fact that they have to stop the drugs, start checking their blood count. Some patients don't even like that at all. And plus with abamacycline, I've seen that with dose reduction to 100 or even 50 milligram, we are okay. So it just depends on the patient before I lean either way. Yeah.
There was a study that came out, I think this week or talking about choice of ovarian suppression in the adjuvant setting and whether 3 months is better than monthly for people with typical skin for monthly ovarian suppression. I think it's mostly cases out of China. But QT, and when I was in clinic, we did Q3. I've never seen anybody do monthly. Is that something that you guys?
Oh, I do Q3. Q3. I mean, because again, who wants to come to the clinic every month? It's just adjuvant. Who wants to come to the clinic every month? All right. Thank you very much for listening. Okay. So our next speaker really is let's see. Let me see if she's gonna beat my time. So I have the pleasure can we put up the next slide? We're going on to the next speaker, right? Of introducing to you Dr. Amina Chudbury. She's a clinical assistant professor and breast oncology in the Division of Oncology at Stanford University School of Medicine. And we're happy to have you back home because this is home for you. She trained at UIC many months ago, and she's recognized for her research in breast cancer amongst minority patients. She has a grant in the Cures Within Reach, where she's studying oral CMC chemotherapy in hormone receptor positive patients. And she has presented in San Antonio, and she recently presented her abstract in the ASCO 2024. Please welcome Dr. Chudbury here.
Hi, everyone. All right, thank you for the introduction, Dr. Ibrahim. It is a treat to be back in Chicago. I practice on the West Coast in Palo Alto, but it is here, like Dr. Ibrahim mentioned, that I fell in love with taking care of breast cancer patients. It is here that I learned the importance of health inequity, clinical trials, and my mentors have taught me how to tackle barriers to clinical trial participation. So super excited to be here. And today I'll be talking about updates in metastatic breast cancer. There we go. So the bulk of my talk is going to be focused on hormone receptor positive updates because in ASCO 2024, San Antonio, a lot of updates were kind of focused on hormone receptor positive disease. I really like the schematic of how we currently treat metastatic breast cancer that's hormone receptor positive, right? Optimal first-line therapy is CDK4/6 inhibitor with endocrine therapy. INAVO120 showed us the advantage of adding inavolisib in first-line poor-risk PIK3CA mutated patients. In the second-line setting, we decide what to do based on if patients have an actionable mutation or not. We have treatments available for PIK3CA mutation, AKT1, PTEN alteration, and ESR1 mutation. And if you don't have an actionable mutation, both post-MONARCH and MAINTAIN taught us that it's okay to switch CDK inhibitor and endocrine therapy in the second-line setting. Other options include everolimus and endocrine therapy, along with standard chemotherapy. And trastuzumab deruxtecan is now a second-line option as well for patients that are HER2 low. And I'll talk a little bit about how DESTINY-Breast06 has changed this algorithm. So let's start with INAVO120, which focused on PIK3CA mutated metastatic breast cancer. Approximately 40% of metastatic breast cancer patients have mutations in PIK3CA, and our current standard is alpelisib and fulvestrant or capivasertib and fulvestrant. We need more effective treatment options in this category because these current treatments don't have a good wide therapeutic index, and they also come with a lot of toxicity. AKT inhibitors and mTOR inhibitors only partially target downstream effects of PI3 kinase, whereas inavolisib is a more selective inhibitor of PIK3CA, so we can combine it with hormone therapy and CDK4/6 inhibitor. Dr. Jurek claims that this triple combination targets all three of these signaling hubs, and early studies suggest synergy if you inhibit all three. Dr. Jurek presented INAVO120, a phase 3 study testing this triple combination at ASCO 2024, and it compares inavolisib, palbociclib, fulvestrant versus palbo and fulvestrant first line in PIK3CA mutated, hormone receptor positive, HER2 negative metastatic breast cancer in patients who relapse during or within 12 months of adjuvant endocrine therapy completion. Eligibility criteria include PIK3CA mutation, a fasting glucose less than 120, A1C less than 6%, hormone receptor positive metastatic disease, or progression within 12 months of completing adjuvant endocrine therapy. So the trial shows improvement in progression-free survival, 15 months versus 7.3 months, with a hazard ratio of 0.43. And you can note the early separation of the curves. I think it's interesting that the control arm has a super steep, you can see that the control arm compared to the Inavo arm, there's a lot of rapid progression in the control. Why is there such a steep runoff? Is it because these patients have PIK3CA mutation? Is it because they have endocrine therapy resistance? Perhaps both. We should also be mindful about the cost of therapy, right? We got to keep in mind financial toxicity, given how expensive first-line use of CDK4/6 inhibitor can be if you add another agent to the mix. So safety, overall, Inavo had a 6% discontinuation rate compared to other PIK3CA inhibitors like alpelisib, which have a discontinuation rate of over 25%. We know well the toxicity of these kinds of drugs, right? The most common side effects include hyperglycemia, diarrhea, rash, stomatitis. These are known adverse effects of PIK3CA inhibition. They were more common in the triplet arm, and they were mostly grade 2 or grade 3. Dr. Jurek claims that patients were able to maintain day-to-day functioning and quality of life while on treatment with little treatment burden. I'm a little skeptical of this, given what seems like a really bad toxicity profile. But overall, it's really exciting, impactful data, and this treatment does seem well tolerated in non-diabetics. It seems promising, but I think I'd have to wait for overall survival benefit before considering use. This combination only increased cost, and our current options are similar in progression-free survival. Next, let's discuss a very interesting case from my colleague, Dr. Wynn's Precision Oncology Tumor Board. Dr. Khan is going to present the case and talk to us a little bit about SOLAR-1, Capitello 291, and Emerald to put these drugs in context.
Hi, everyone. I'm Sarah Khan. I'm the Hematology-Oncology Fellow at Rosalind Franklin University of Medicine and Science. And thank you, Dr. Chaudhry, for letting me present this very interesting case. This patient was seen at Mount Sinai Hospital, a 55-year-old female who was diagnosed with left-sided breast cancer, HR positive, HER2 negative, in 2011. And she underwent left-sided mastectomy, followed by adjuvant chemotherapy and radiation, and then adjuvant hormone therapy with tamoxifen for almost 9 years. But in late 2021, she developed new vertebral lesions with compression deformities, which biopsy proved that they were metastatic disease, for which she underwent radiation. She was started on letrozole and then in early 2022 with palbociclib, which was later switched over to abemaciclib due to toxicities. In late 2023, she developed new liver lesions, and liver biopsy again proved that this was metastatic breast cancer, again, HR positive, HER2 negative. At this point, she was started on fulvestrant. And she did undergo at this point a liquid biopsy, which showed ESR1 and PIK3CA mutations. Her germline testing was negative. So in patients who have 2 actionable mutations, which targeted treatment should be initiated first? A, alpelisib, B, capivasertib, C, inavolisib, or D, elacestrant, or E, larotrectinib. This brings us to our therapeutic options, alpelisib and capivasertib. Alpelisib was evaluated in the SOLAR-1 study, which was a study evaluating postmenopausal women or men with HR positive, HER2 negative advanced breast cancer. The participants could have 1 or more prior lines of hormone therapy, but no chemotherapy for advanced breast cancer, although they could have received it in the neoadjuvant or adjuvant setting. The key findings in the study were the median PFS was 11 months in the alpelisib arm compared to 5.7 months in the placebo plus fulvestrant arm. Then looking at the Capitello 291 study, capivasertib, which is basically a small molecule inhibitor of the AKT pathway, showed it evaluated patients who were pre, peri, or postmenopausal women or men with HR positive, HER2 negative advanced breast cancer who had relapse or disease progression during or after treatment with an aromatase inhibitor with or without previous CDK4/6 inhibitor therapy. And in this, the key findings were the median PFS was 7.3 months in the capivasertib fulvestrant arm compared to 3.1 months in the placebo arm. Some key differences between these two studies was that the SOLAR-1 study, it excluded patients who had received chemotherapy for the advanced cancers, whereas Capitello did allow it in some circumstances. Coming to our next therapeutic option, which was evaluated in the EMERALD study, and this was evaluating elacestrant, which is a SERD. And this was, enrolled patients with HR positive, HER2 negative breast cancer who had received 1 or 2 lines of endocrine therapy, and it had to include a CDK4/6 inhibitor. The patients were randomized to receive either elacestrant or a standard endocrine monotherapy, and either fulvestrant or aromatase inhibitor. And the key endpoints was progression-free survival in all patients, and specifically in patients who had ESR1 mutations. It was found that the PFS was prolonged for treatment with elacestrant compared to those receiving standard of care. In the overall population, as well as in those who had ESR1 mutations. The median PFS was 3.8 compared to 1.9 months. However, the median PFS was not so reliable in this case due to early drop in the PFS. And the 6-month and 12-month PFS showed better responses, 40% in the elacestrant and 18% in the standard of care was the 6-month PFS. Then coming to the INAVO 120 study, as Dr. Chaudhary already talked about, it showed statistically significant and clinically meaningful improvement in the PFS, 15 months compared to 7.3 months. And there was sustained benefit beyond disease progression. There was delayed need for subsequent therapy, including chemotherapy, by about 9 months. There was also improvement in patient-reported outcomes, specifically deterioration in pain. Pain was about 12.8 months in patients receiving inavolisib. Inavolisib discontinuation rate due to adverse events was also lower, only 6.2% compared to some earlier PIK3CA inhibitors. If you look at the NCCN guidelines, though, the PIK3CA inhibition and AKT pathway inhibition is actually category 1, and ESR1 mutation inhibition with elacestrant is category 2A. There is actually no specific data that we know of, or I know of, that prioritizes one over the other, inhibiting PIK3CA over ESR1. So in this patient with 2 biomarkers available with FDA approvals, what would be the preferred therapy? The NCCN recommends using PI3 kinase targeting with fulvestrant as category 1 and elacestrant as category 2A, which gives us 2 options of alpelisib versus capivasertib. Alpelisib has better, more convenient dosing, but it has a risk of hyperglycemia, which requires monitoring. While capivasertib, it has broader pathway inhibition. Although it has a more complex dosing schedule, but there's less risk of hyperglycemia, less risk of adverse drug reactions compared to alpelisib, which in some patients might make it a better option. And with this, I'll hand it over back to Dr. Chaudhary to continue the rest of the presentation. Thank you.
Thank you, Dr. Khan. So I have a question for those of you that have been keeping up with perhaps the most exciting update in metastatic breast cancer this year, DESTINY-Breast06. So DESTINY-Breast06 compared trastuzumab deruxtecan to first-line chemotherapy in patients with endocrine refractory, hormone receptor positive, HER2-low, or ultra-low metastatic breast cancer who have had prior endocrine therapy, CDK4/6 inhibitor, or targeted therapies and experienced disease progression. Which of the following statements best describes the outcome of the trial? A, significant progression-free survival benefit with trastuzumab deruxtecan, with median progression-free survival of TDXD at 13.2 months versus treatment of physician's choice at 8.1 months. B, significant overall survival benefit with trastuzumab deruxtecan. C, significant progression-free survival and overall survival benefit with TDXD. Or D, significant progression-free survival with TDXD only in the HER2-low population, but no progression-free survival in the HER2 ultra-low. Well done. Yes, nice job, guys. So A is the correct answer because trastuzumab deruxtecan did show significant progression-free survival compared to standard of care chemo in both HER2-low and HER2 ultra-low. B and C are incorrect because we don't know if there's overall survival benefit yet, right? These overall survival results are immature at the first interim analysis. And D is incorrect because we saw improvement in both HER2-low and HER2 ultra-low with TDXD. So let's break down DESTINY-Breast06. This trial looked at Enhertu or trastuzumab deruxtecan for hormone receptor positive, HER2-low or ultra-low metastatic breast cancer in patients who have had prior therapy but experienced disease progression. And they either received Enhertu or chemo. And before we talk about the results, let's put this in context. What we do now, if you're HER2-low, is endocrine therapy, targeted therapy, then you get chemo, and then you get Enhertu. And what DESTINY-Breast06 is trying to look at is, can we give Enhertu before chemo? How is that going to impact outcomes? And can we also give it in the HER2 ultra-low patient population? You might be wondering, what the heck is HER2 ultra-low? In metastatic breast cancer, we've got HER2 negative, HER2 low, and HER2 positive. Ultra low is a new category where you've got some HER2, but it's not high enough to be considered HER2 low. HER2 low is IHC 1+ or 2+, but HER2 ultra low is IHC 0 with less than 10% staining. And right now, this is not being reported on path reports, right? We will have to work with our pathologists for this classification, which does not sound fun. And I'm also really concerned about this in community hospitals where there isn't as much interaction between the oncologist and the pathologist. So results from DESTINY-Breast06, patients that got Enhertu had a 37% reduction in risk of progression or death. That translated to a 5.1-month improvement without disease progression. Patients that received chemo had average PFS of 8.1 months compared to 13.2 months in patients that received Enhertu. Results in the ultra-low population were the same as HER2-low. And again, overall survival data is immature, but you do see a trend towards improved overall survival with trastuzumab deruxtecan. The response rate was 57% with trastuzumab deruxtecan compared to 31% in treatment's physician's choice. So exciting trial, promising results, but I had a few concerns that I wanted to talk about with you guys today. Firstly, why were there no anthracyclines in the control arm, right? I feel like there's many chemo options that are missing that are listed in NCCN, and I was surprised they chose Xeloda, Taxol, and Abraxane. Abraxane is inferior to Taxol, and I don't think that restricted choice is a good thing in this setting. Secondly, very sadly, only a minority of patients in the control arm received trastuzumab deruxtecan after progression, less than 20%. And this makes it really hard to know if first-line treatment is really superior in terms of survival, right? This is open label design. People can drop out, and we have to ask ourselves, is it going to be the poor person in Eastern Europe that's going to drop out because they're randomized to the control arm? Or is it going to be the wealthy, connected person at MD Anderson? And I think if you have dropout not at random, but rather based on patient characteristics, that's going to taint your results. and it's going to violate Kaplan-Meier assumptions. Thirdly, I'm really worried about how we're going to report HER2 ultra-low status. One idea I had was, could we report it as IHC equals 0 with a little star, and the star could represent faint, incomplete staining. And we also have to be mindful about toxicity, and HER2 does have more side effects. It had an 11% incidence of interstitial lung disease and pneumonitis, and 3 of these patients died. And so I think while we're waiting for FDA approval on this data, we will likely see increased use of second and third line trastuzumab deruxtecan in both the HER2 low and ultra low population. Next, we're going to talk about the long-awaited post-MONARCH. I'll start by talking about abemaciclib, right? Abemaciclib is a CDK4/6 inhibitor with greater selectivity for CDK4 than CDK6. What's nice about that is it allows us to do continuous dosing with less myelosuppression, but that comes at a cost we know well. Dr. Ibrahim talked about diarrhea. Previously seen phase 2 studies looked at continuing CDK4/6 inhibitor after progression on prior CDK4/6 inhibitor and switching endocrine therapy, but these studies have shown pretty inconsistent results. We've got progress with targeted therapy that Dr. Khan talked about, post first-line CDK4/6 inhibitor, but the progression-free survival of these drugs is less than 6 months, toxicities vary, and they have high discontinuation rates. So post-MONARCH included patients with hormone receptor positive, HER2 negative advanced disease. These patients had progression on CDK4/6 inhibitor and aromatase inhibitor as initial therapy for metastatic breast cancer, or they had relapse on or after adjuvant CDK4/6 with endocrine therapy for early stage disease. No prior therapy for advanced breast cancer or chemo was allowed. Patient characteristics, they were pretty well balanced among both arms. 60% had visceral metastasis, and almost all patients received prior CDK4/6 inhibitor in the metastatic setting. Prior CDK was 60% palbo, a third ribo, and 8% abemaciclib. We saw improvement in progression-free survival with abema and fulvestrant, with median progression-free survival of 6 months compared to 5.3 months in the placebo arm. And then when we look at the benefit among all the subgroups, there was benefit in abema among all subgroups, but we did see a greater magnitude of benefit in patients without visceral metastasis. So post-MONARCH take-home messages, adding abema to fulvestrant, post-CDK4/6 inhibitor, mostly post-palbo, improved PFS with a small median but significant hazard ratio. Patients who had received CDK for longer duration without visceral metastasis had longer progression-free survival. And I think it's okay to switch CDK inhibitor at progression. This is a good option in the second-line setting, especially in the absence of a targetable mutation. Moving on to HER2 updates. Some big questions here. Firstly, what are optimal second and third line treatment options for HER2 positive metastatic breast cancer after trastuzumab deruxtecan? And secondly, how do we integrate CDK4/6 inhibitors with endocrine therapy in triple positive metastatic breast cancer? So here's a picture that kind of is showing us the evolving treatment landscape of HER2 disease. And before trastuzumab, breast cancer was associated with high recurrence and reduced survival, right? Luckily, trastuzumab has dramatically changed the game. We have better outcomes, but we still have a long way to go. Right now, there are 8 FDA-approved HER2 targeted agents, including 4 that were approved in the past 5 years. And sadly, despite this rapid progress, I have learned in my short 8 months of practice that many patients with metastatic HER2 positive disease will die when their disease progresses. And it's kind of confusing because some of these drugs offer, good overall survival, but that's often offset by the increased incidence of brain metastasis. And that can make treatment selection pretty challenging. So here's our current algorithm. We start with THP, followed by trastuzumab deruxtecan. Third-line options include tucatinib, capecitabine, and trastuzumab per HER2 or TDM1. And then in the fourth line and beyond settings, we usually use kinase inhibitors with HER2 monoclonal antibodies. How do we treat triple-positive metastatic breast cancer? I think we often underutilize targeting the estrogen receptor and hormone receptor positive, HER2 positive advanced breast cancer. And maybe if we block the estrogen receptor and HER2, we could overcome resistance and reduce the use of chemotherapy. Treatment sequencing can be confusing in this setting. There's something called PAM50, which I learned about at ASCO 2024. Intrinsic molecular subtypes like PAM50 can help identify patients for endocrine therapy, CDK4/6 inhibitor, and HER2 targeted therapy. Patricia is a phase 2 trial in patients with triple positive advanced breast cancer who have luminal A or luminal B on PAM50 gene expression profile. Inclusion criteria included patients should have been treated with at least one prior line of therapy, including trastuzumab, ejection fraction greater than 50%, and no prior CDK4/6 inhibitor therapy. It compared palbo, trastuzumab, and endocrine therapy versus treatment of physician's choice. And these were the options for treatment of physician's choice: TDM1, trastuzumab and endocrine therapy, or trastuzumab and chemo. Chemo options were gem, vinorelbine, cape, or taxane, and of note, trastuzumab deruxtecan and tucatinib were not included as options. Results of Patricia. At median follow-up of 26 months, progression-free survival was better in the triplet arm at 9.1 months compared to 7.5 months in the treatment of physician's choice arm with a hazard ratio of 0.52. Overall response rate was also higher in the triplet arm at 19% versus 7%. Safety profile was manageable with similar dose reductions in both arms, and the most common side effects were neutropenia, grade 3 or 4, followed by fatigue, followed by anemia. So takeaway messages of Patricia. Monarch HER previously showed us good results with abemaciclib, trastuzumab, and endocrine therapy. And now Patricia shows us good progression-free survival and tolerability in the ER-positive subgroup with palbociclib. The biggest limitation here was they weren't able to reach their recruitment goal, and so the study was underpowered. Still exciting data. Progression-free survival was prolonged by 6 months, suggesting that luminal intrinsic subtype may be a good biomarker to select patients for triplet therapy. I'll end by talking about a study update from triple-negative breast cancer. So enfortumab vedotin, which is a Nectin-4 antibody drug conjugate, right? Nectin-4 is highly expressed in epithelial cancers and breast cancers, and it's really revolutionized outcomes for metastatic bladder cancer. EV202 tested enfortumab vedotin in hormone receptor positive metastatic breast cancer and triple negative breast cancer. Kind of exciting. No antimicrotubule antibody drug conjugate has kind of been looked at in the triple negative space. Enfortumab vedotin did show modest anti-tumor activity in both the hormone receptor positive and triple negative cohorts, though the objective response rate threshold was not met. Interestingly, Nectin-4 was highly expressed in both cohorts. Response rate was not dependent on Nectin-4 expression. So I think it's an exciting future potential way in the future potential option for metastatic breast cancer. And I'm excited to see further studies with or without checkpoint inhibition. And I think we should also, combine it with immunotherapy. Future directions. We are continuing to move away from chemotherapy as much as possible in metastatic breast cancer. I think we're going to see an increasing role for immunotherapy in the future. And we really need to keep working on sequencing and transitioning between antibody drug conjugates and other drugs. I find that really challenging in clinic, the sequencing and the order of these drugs. And so I'm looking forward to more clear updates that provide us guidance for how to take care of patients with metastatic disease. Thank you. Any questions? Yeah. That is a really good question. And I'm not thinking very clearly through it. I think it's very confusing when we use CDK4/6 inhibitor adjuvantly. And then we see women 5, 6, often 10 years later, especially in hormone receptor positive disease, when they develop metastasis. Do we, continue CDK4/6? Should we, do another option? I think it's okay to continue CDK4/6 at progression. And I think maintain and post-monarch help support that. But that's just my preference. Yeah. It's a great question.
You're talking about switching to CDK4/6 inhibitors, but we also saw some great data that's as well about the 3 different options we have in the PIK3CA pathway now. Like, is there any data or research or thoughts about patients who have progression on one agent switching to another, or if they're having maybe a lot of toxicity with alpelisib, switching them to CAP or alpelisib? How do you think about that paradigm?
That's a really good question. I'm someone who prefers CAPI to alpelisib to begin with. Like Dr. Khan mentioned, we've got wider therapeutic index. It's going to take care of AKT, PTEN, and PIK3CA, whereas alpelisib is focused more on PIK3CA. CAPI did have a lower progression-free survival than alpelisib. But in terms of switching between, these antibody drug conjugates, I'm not sure how I would address that. It's a good question. Big time. So I think that was kind of exciting with capivasertib. I think it's a much better option for diabetics than alpelisib. And I was really bummed at the eligibility criteria of Inavo, right? They wanted patients with blood glucose less than 120, A1C less than 6%. And so I feel like Inavo is better for non-diabetics, but we're still kind of stuck at, how do we decide when patients have high blood sugar or poorly managed diabetes? But I think capivasertib kind of wins when it comes to poorly controlled blood sugar and diabetes. That's a really good question. I don't think it's going to hold in the community setting, and I'm really concerned about using triplet therapy first line in community setting. It's going to be really tough to get insurance to cover it first line. It's going to be tough to pay for it, right? We're adding another expensive agent to CDK4/6 first line now, and I think it's going to be challenging for community hospitals to be able to provide that for patients, especially patients with lower socioeconomic status. Absolutely. Yeah.
Thank you for a great overview. You showed the treatment algorithm for competitive metastasis. So at what point during the therapy would you consider that triple targeting approach with endocrine therapy or directed therapy?
I think the data from ASCO 2024 is now having us consider first-line use of CDK4/6 inhibitor with trastuzumab and endocrine therapy. I don't know how that's going to translate yet without FDA approval, but I think we are going to start using, we're going to start noticing more use of triplet therapy first line. Yeah. That is a very important unmet need right now. Unfortunately, the community is not aware of all of these treatment options. I practice in Palo Alto, and when I first took my job, I was excited to work with patients in Oakland and Emeryville. to talk to them about metastatic disease, talk to them about breast cancer, talk to them about clinical trials. Unfortunately, my job still has me stuck in Palo Alto, and I'm trying to break through to admin, to be more active in other sites. That's a good question. We need more work and effort in that space and really educating our patients, especially in the community setting.
Everyone's interested in this with HER2 testing, like what's the HER2 positivity now? Have tumor agnostic HER2 approval now. But with this ultra low, you mentioned it already. How are those discussions with your pathologist right now? Because I'm discussing with our pathology team, to start doing HER2 testing of advanced lung cancer. But how do you discuss that with your pathologist? Like, what do those discussions look like right now?
It's interesting you asked that. We just had a meeting with our pathologist on Friday on how we're going to do HER2 ultra low versus HER2 low, and they are not looking forward to it at all. They kind of talked to us about even when patients are HER2 low, like even designating them as HER2 low has so much gray area that how in the world are we going to start designating patients as HER2 ultra low, right? Like that faint staining, it's kind of like counting dots almost. Like I made a pathologist show me how they decide HER2 low, and it's very like not clear cut, or like it's kind of gray. And so I am worried about HER2 ultra low and HER2 low report. Yes. That is a great idea, Dr. Ibrahim. One thing to look forward to at ASCO 2024, artificial intelligence and HER2 reporting. I like it, Dr. Ibrahim. Totally. All right. Yeah.
You have algorithm for obviously whatever one is also doing new testing at a certain time.
I usually repeat CT testing at progression. I have a lot of patients who ask me at random intervals now to get ctDNA testing. And unfortunately, where I practice, I notice a lot of my providers that work with me kind of give in to patients asking for this. But I don't think it affects management. I don't think it affects outcomes. It's expensive. So I'm someone who likes to get it only at progression. Interestingly, I think SOLAR 1 and Capitello 291, SOLAR 1 looked at both, blood biopsy and looking at the tumor for ctDNA versus Capitello only looked at looking at the tumor specimen. And so even like, kind of deciding between liquid biopsy and deciding whether we should get, the tumor for ctDNA, that alone is kind of gray. And I think we need better guidelines to make that decision.
So like, what I'm hearing now is once a year, well, like 2 years, they
Yes, I think that is a great time to repeat ctDNA testing when you're worried about loss of ER, right? Especially when there's discordance in the original profile versus at progression. I think that's a good time to test ctDNA. Thank you, guys.
Very different fellowship. Yeah.
Yeah, thank you.
Yeah. I want the whole, scene with it. Here's my 2050. Yeah, no, I have it, but I'm sure you have. Yeah. Yeah, yeah. They've done their own cuts, right? Interpret that. Wow. Okay. Okay. I think. Yeah. It's hard for us to keep up. Like, you know, I like that part is one area where I feel like they got fascinating order. That's my favorite thing right now. Yeah, yeah. Okay.
Thank you. I was just trying to figure out how to get it. No. Something with the display monitor.
This is the HD monitor. Now you're going back to where you were before.
But maybe make a note for Jimmy so that we can figure out how to have it set for them going forward.
Yeah, it's not a conference monitor.
To show presenter.
Yeah. So this.
Oh, yeah.
That's where the junction.
Well, no, but I took that case out and then set it up. So, I think it's- but I think we have to just put it on here. I can figure it out. I'll get it. Okay. Well, I think that's.
All right, welcome back, everyone. Are we waiting for anyone to from outside to please join us in? All right. So we're going to continue our summer CME series with our next speaker, Dr. Natal Racine, my friend, my former office mate. So, and yeah. And I want to believe that that room is going to be meant for people that go on to do great things. She was in that room, I was in that room, and Karen is in that room. So maybe the room is going to be a place where we give to people if you want to do great things. So she's she presently heads a GU oncology team, and she's an assistant professor in a division of hematology oncology at Department of Medicine. She earned a medical degree at Loyola, and she completed internal medicine residency at University of Chicago. She also did ethics fellowship there, and she also did her fellowship there, and also is a clinical pharmacology and pharmacogenic fellow. So her research interest is in, of course, clinical trial diversity, and she specializes in GU cancers, particularly prostate, kidney, and bladder cancers. And like I said, she's also interested in personalized medicine for her patients. And most importantly, she has a lovely baby son. So please join me to welcome my friend, Dr. Ethan.
This is fun. Okay. All right. Well, thanks for being here today, everybody. I'm Natalie Razine, GU Medical Oncologist. We are going to go through a little bit of the landscape with prostate cancer and some recent trials and approvals that we've had, just as kind of a high-level update. So in terms of what we're going to talk about today, as I just mentioned, we are going to talk about the landscape, mostly about advanced disease treatment options, as I'm a medical oncologist. That's mostly where my role steps in. We'll also make some comments about how we do therapeutic sequencing, especially in this changing landscape as we're intensifying therapies earlier and earlier. We will talk about the role of next generation sequencing in prostate cancer, as well as kind of the birth of targeted therapies for prostate cancer. And we will end with probably the most recent entrance of targeted therapies in prostate cancer, which is radioligand therapies. So for those who maybe don't treat prostate cancer every day, when we think about prostate cancer, just like other solid tumor malignancies, we of course care very much whether it's localized, advanced, or metastatic. But another important feature of prostate cancer is its hormone responsiveness status. So whether or not a patient is castration sensitive or hormone sensitive or hormone naive versus castration resistant. And what that means is that basically the prostate cancer will regress after you remove the testosterone in the patient's in a castrated setting. Eventually, if you give prostate cancer enough time, all of it will develop castration resistance through a variety of different resistance mechanisms. And as you can see, unfortunately, usually that corresponds with the disease course going on and on. Mortality does increase at that point. And, a lot of our therapies were developed in this space. So as a medical oncologist, these are kind of the disease states that I mostly see for prostate cancer. So we do start taking care of patients in the high-risk localized disease setting. And that's due to pretty recent data actually showing that intensification beyond ADT with abiraterone, as well as radiation upfront per the STAMPEDE trial, improves progression-free survival and overall survival, even in localized disease setting. Very recently, we also had another indication in the setting for enzalutamide with or without ADT after patients have progressed after receiving local therapy and their PSA is rising. We now have the option to give enzalutamide even in this early space. Once you get into the metastatic disease setting, it's been very well established from all of these trials and for many years that intensification beyond androgen deprivation therapy is definitely the standard of care. So you have a number of options here. You have taxane chemotherapy with docetaxel per the CHARTED trial, and you have a number of second-generation androgen receptor pathway inhibitors that I've listed here. Typically, when we talk about metastatic prostate cancer, it's when we're talking about choosing our targets, it's less of a biomarker informed strategy at this point. It's pretty much biomarker agnostic. What we do use is the clinical cutoff of high volume versus low volume disease, which you can see the CHARTED criteria are listed right under high volume metastatic disease. For the last year and a half, we have had data that shows that triplet therapy, so ADT plus androgen receptor pathway inhibitor plus taxane chemotherapy for those who have high volume disease and meet criteria for taxane therapy is the way to go to improve outcomes as much as you can. And then we really don't have a role for targeted therapy or personalized medicine until you get into the castration-resistant prostate cancer setting in terms of FDA approvals, when we definitely need to make sure that we're assessing for HRR mutation status as well as PSMA avidity on a PET scan. But, I kind of show all of this because, in terms of when we think about advanced prostate cancer, just like in all other forms of medical oncology, when we have a good drug, it normally starts in the later lines of disease. And if it works and it's tolerable, we move it earlier and earlier. So we're seeing that shift, not just in prostate cancer across the board. Specifically, I'm thinking about lung cancer. We're seeing everything move earlier and earlier, but my question, particularly for prostate cancer, is what are we doing to the disease biology in this space? And because most of these patients are going to be receiving these therapies earlier and earlier than when they were originally studied, it can be very difficult to extrapolate some of the recent results that we've had to the patient that's sitting in front of you. So an example of that is we actually just had recent update at ASCO just a couple weeks ago with the CHARTED 2 trial. So the CHARTED 2 trial was, of course, the follow-up to CHARTED 1. So Charted 1 enrolled patients with castration-sensitive metastatic disease to receive ADT plus docetaxel alone. So no androgen receptor pathway inhibitor, as it predated that data. So in Charted 2, it was those same eligible patients. They did not receive androgen receptor pathway inhibitor in the castration-sensitive setting. And then they were randomized to receive cabazitaxel with or without abiraterone. So that was their first exposure to an androgen receptor pathway inhibitor. This was just presented a couple weeks ago. And the primary endpoint was progression-free survival. And as you can see, it did meet its progression-free survival benefit. So particularly in patients who were younger, had more visceral disease, had a faster development to castration resistance, the combination regimen seemed to do better. I think that makes sense from kind of a tumor clonal, like, disease burden perspective. This study was not powered for overall survival, but the curves do overlap. And as you can see, the combination had an increased change in the PSA as well. But I think while, we've definitely seen a lot of rationale for more drugs maybe are better, I think that very much depends on the disease setting. And again, even though this trial was, it was conceived in the pre-triplet therapy era and also enrolled in the pre-triplet therapy era, you can see how this data can be difficult to apply to the patients who may have received an androgen receptor pathway inhibitor going forward. However, there will be a number of correlative studies. We'll look at different genomic features of these patients, and I think there will be a certain population for whom it will be appropriate to intensify, even if they've had more therapies early on. So, it was mentioned in the introduction, a big interest of mine is precision medicine and prostate cancer, of which I think we're making significant headway, but I think we are behind other solid tumors because most of our therapies do involve AR manipulation. I have this nice graphic from a review article that I think very nicely summarizes a lot of prognostic variables that we look at. They're not very predictive for what therapies to select, apart from, of course, the very rare microsatellite unstable that you may see. And then, of course, HR alterations, the most prevalent one is BRCA2. And that's a nice segue into the entrance of PARP inhibitors into this space. So over the last couple of years, we've had a flurry of FDA approvals looking at PARP inhibitors, regimens, both as monotherapy and combination therapy, all approved within the metastatic castration-resistant prostate cancer space. And this interest in the field was originally borne out by this landmark paper published in New England Journal in 2016 that did germline profiling of advanced prostate cancer patients and found that it was, HR alterations were pretty prevalent. And that's important, not just for, of course, targeted therapies and PARP inhibitors, but for these men's families. So there was a really big push to do genetic testing. It even is up to 6% if you look at localized high-risk patients, which again is important for patients and their families. And if you include somatic HR alterations, some studies suggest that it could be up to 20%. This is important because, as I mentioned, of course, we now have a therapy for this, but we know even before that BRCA mutated prostate cancer patients do worse. They do worse on our standard therapies despite what you do, and they are a different disease biology and need treated differently. So, of course, PARP inhibitors have probably been mentioned in the CME series before. They are approved in many other types of solid tumor cancers beside prostate cancer. For the sake of time, I'm not going to go through the mechanism of action, but the idea is that if you have a tumor which is HR deficient, they are going to be even more sensitive to PARP inhibition once you do that pharmacologically and result in synthetic lethality and preferential tumor cell death. So because of all of this information, it's been part of the guidelines, NCCN guidelines, to do genetic testing in almost every prostate cancer patient, certainly that I see as a medical oncologist. You can see that it's recommended even in high-risk localized prostate cancer. And of course, once you get into the advanced or metastatic disease setting. And then somatic testing is definitely recommended once you get into the advanced or metastatic disease setting as well. I usually just order them concurrently. And this is Dr. Wynn's favorite slide that I've ever made in my entire life. But Well, if it's still relevant, yeah. But I actually made this to keep myself organized because there was a while where it was just PARP inhibitor after PARP inhibitor that was coming out for prostate cancer. And as you can see, although BRCA1 and BRCA2 mutations are approved across the board, the other biomarkers do not match. So it can be very confusing when you're reading different reports to remember which of the HRR mutations are approved for which of the different drugs. So I originally made this to organize myself, but I'll keep adding to it. And it's important to note that because while I think the role of PARP inhibition is very well established in BRCA mutations, this is from the original PROfound data, that not all of these HRR mutations respond equally to PARP inhibitors. And this has been borne out across many different, all of the different PARP inhibitor studies, if you look at all of the different exploratory analyses. So if you look at the top line, BRCA2, the print's a little small, I apologize, but it's pretty respectable numbers, 81 and 47 in the control arm that were randomized in the PROfound study. And you can see a pretty, sizable difference in how the patients with BRCA2 mutations did if they received a PARP inhibitor versus if they didn't. But when you get to things like ATM, even though the numbers are pretty good, the benefit becomes a little less, a little fuzzier, I would say. And then certainly once you get down into these mutations where they're very rare, like RAD51B, where there was only one patient in the control arm. I mean, it's approved in that setting, but I think it can be very hard I think it's hypothesis generating at this stage. It can be very difficult to determine whether or not that's the drug you should pick for your patients if you have other agents available. Another question in the PARP inhibitor field for prostate cancer is whether or not the combination strategy matters or if sequential therapy is enough. We don't have very much data on this, unfortunately, but we do have the BRCA trial, which was a small study presented last year by Dr. Hussein, where patients who were first-line metastatic castration-resistant prostate cancer, so again, had not received an androgen receptor pathway inhibitor, were randomized to receive the combination of abiraterone plus olaparib, or they received one versus the other and then received the other one once they progressed. And what you can see from this data, again, the numbers are very small, is that there does seem to be a benefit to the synergistic concurrent treatment strategy, which does support preclinical data. But again, I mean, this is the same remark that I'll make with the CHARTED-2 data. It can be very difficult to apply this to your patients who probably received androgen receptor pathway inhibitor prior to developing castration resistance, and whether or not this concurrent strategy is still the way to go versus if you're going to have increased toxicities. So there's a lot of people looking at that, but mostly retrospective. And another important point for HRR mutations is that it's very important to remember who was included in the panels that created, what is our reference for what we think is normal in prostate cancer. So we know that not all individuals of all demographics have the same incidence of actionable alterations. This has been published many times. Dr. Twaji and I will be publishing the UI Health experience as well soon. But this was a paper published just several years ago that tested, it did a germline panel in Black versus white men. And you can see that the rate of pathogenic variants was half that in Black men versus white men. And they had a much increased rate of variants of uncertain significance, which is very important to counsel patients about what that means. And so it really, impresses upon the importance of having genetic counseling built in. And as I said, we're not there's been many people who've published on this just recently. GU ASCO, this exact same trend was seen in the Latinx population, and it's been borne out amongst diverse patient populations. So we really need to make sure that our biomarker testing and discovery is equitable and including all patients so that we're making sure that our drugs are going to treat all patients with prostate cancer. And then PARP inhibitors, although, I think they're kind of in a defined role at this time for prostate cancer, we are going to see a number of studies in the next couple of years that will be borne out because in medical oncology, once you have a good drug, why not combine it with another good drug? And that's what we do over and over again. So this is a non-exhaustive list that Dr. Twaji and I have put together of just combining PARP inhibitors with things that preclinically seemed to make sense in terms of a combination strategy. So stay tuned. I think you'll see a lot of these coming out within the next couple of years. And I put this slide in basically because I think it's very confusing. I think it's great that we have so many options for metastatic prostate cancer, but it's incredibly confusing. Like reading the NCCN guidelines as a fellow, it can be very confusing figuring out where does my patient fit into this box in terms of what they've received before. It's good to have options, but it can be, that's part of what I love the most about prostate cancer is the nuances of sequencing, although we don't have a lot of data in this space. Very, very recently, although I mean, I guess it's been 2 years now, we had an approval of a radioligand therapy for PSMA positive metastatic castration resistant prostate cancer. We, of course, have had Xofigo or radium-223, which I think is an excellent radioligand, but unfortunately only works for bone only disease. So it can be somewhat limited in the castration resistant setting space. But of course, we now have lutetium PSMA approved after patients have progressed on an androgen receptor pathway inhibitor and a taxane. So PSMA is actually a cell membrane protein, prostate-specific membrane antigen that's highly expressed on the surface of prostate cancer, expressed on most prostate cancer, particularly earlier in the disease course. It was first developed as a diagnostic tool for PET CTs, of which there's a number that are approved in the United States. And we get them as part of the workup for prostate cancer patients. So when they're initially diagnosed to determine whether or not they have metastatic disease or are eligible for curative intent. And then of course, as we follow patients over time, and then to determine if they're a candidate for radioligand therapy. So what is radioligand therapy? So I will call your attention to the top. So because we're going to talk about radioligands as a whole class. So in terms of what lutetium PSMA is it's a PSMA binding motif in green there that gets trafficked to PSMA expressing cells. It's then attached to a linker, which connects it to a beta particle, which is a type of radiation. And then it gets taken up by PSMA expressing cells, internalized into the cancer cell, and then of course releases its radioactive compound and hopefully causes selective tumor death. Currently, it's approved for 6 injections about every 6 weeks. It's a relatively new therapy. It seems to be pretty well tolerated. We know that there's a long-term nephrotoxicity that we don't quite understand the mechanism of, so hydration is really important. Other side effects are bone marrow suppression, as well as salivary gland toxicity because PSMA is also expressed in the salivary glands. And this was originally approved based off of this study done several years ago, now the phase 3 VISION trial that enrolled the patient population for which it's currently approved, which are metastatic castration-resistant prostate cancer patients who have progressed on androgen receptor pathway inhibitor and chemotherapy. They were randomized to the lutetium PSMA arm versus standard of care. Important to note that the standard of care arm did not include chemotherapy, so normally it was an androgen receptor pathway switch. And then patients went on for the 2 endpoints of progression-free survival and overall survival, of which it met both, which led to the FDA approval now 2 years ago, as I mentioned, almost 2 years ago. I want to highlight this therapy trial, which is a phase 2 study, not just because we're seeing more and more correlative information come out of these studies, but also because I think it still informs about this drug. So patients, very similar disease space, metastatic castration-resistant prostate cancer, but in this case, they actually had to be suitable for cabazitaxel, which is, of course, a standard of care. And then patients were also stratified, and they were very selective about their PSMA avidity on the PET scans. So this study really established PSMA avidity as a biomarker for response to lutetium PSMA. The patients were randomized to lutetium PSMA versus cabazitaxel. The primary endpoint was PFS, which it did meet, but importantly, it also had reduced toxicities and improved quality of life. And this was consistent in the most recent final publication of the secondary outcome of overall survival. Overall survival actually was equivalent between the 2 arms, but the lutetium PSMA arm did have an improved quality of life and lower side effects. just like, as is our theme, we have a good drug, we move it early, we need to combine it and move it earlier and earlier. So this is a non-exhaustive list of trials that will be reported out very soon, I'm sure, looking at lutetium PSMA in earlier prostate cancer disease settings. We do actually have data from the PSMA-4 data. This has been presented multiple times, most recently at ESMO and GU ASCO, which is a castration-resistant prostate cancer disease setting, but pre-taxane. And patients were randomized to an androgen receptor pathway switch. So we do have data from that. This is just a study schema, just to remind you of the study design. So again, patients progressed on an androgen receptor pathway inhibitor. They were very selective in terms of the patients that they picked with the PSMA avidity and not having a PET scan that was discordant. And then patients had to be taxane naive, not candidates for a PARP inhibitor because of an HRR mutation. And they also had to be candidates for a change in androgen receptor pathway inhibitor. So this study is very interesting. It's received, some criticism about the control arm not being chemotherapy, but as the authors state, they very carefully selected for patients who they thought could go on to an androgen receptor pathway inhibitor change. And as you can see, crossover was allowed, and the crossover rate was like in the 90s. So like most patient on the androgen receptor pathway inhibitor did eventually receive Pluvicto. And it did meet its, the overall survival data is still immature, did meet its progression-free survival benefit. And we did just see some updated data, both from a correlative space at ASCO, but also from quality of life. So there were a number of different quality of life metrics. Quality of life basically is improved across the board with the lutetium arm. So it's met these numerous different quality of life scores. And this is a summary that I took from the ASCO discussant, Dr. Paller, where she compared and contrasted all of the recent phase 2 and phase 3 lutetium PSMA, and shows that it consistently does seem to improve healthcare quality of life. So I mentioned this because I do know that they are seeking approval in the pre-chemotherapy space. So I think this is important to keep our eyes on, because of course this would be practice changing if we had this option as a pre-chemotherapy, particularly for patients who we don't think are fit for chemotherapy. I think there will be a number of correlative studies to help us more carefully select that, such as ctDNA burden and things like that for patients who may be more appropriate for chemotherapy. But I also say this, if you don't have friends with a nuclear medicine doctor, you need to be friends with a nuclear medicine doctor, because this takes a lot of coordination and really is quite an investment on the institution's front. And we had a supply chain shortage with this agent when it was first approved, even in places that had been offering it for a while. So we really need to make sure that we're offering equitable access to this agent, especially if it gets moved earlier and earlier. And again, it's being combined with many different things. So again, we are going to see a lot more about the lutetium PSMA compounds and whether or not we can have synergy if we can sequence therapy so that we upregulate the PSMA target if someone has stopped expressing it, et cetera. And to close out, I'm just going to kind of show this slide just to show you that we've barely touched the surface just with talking about lutetium PSMA here, which of course is a radioconjugate. We only talked about the two studies, were the two lutetium PSMA compounds. We only have one that's currently approved, but we'll see data for the other, the INT compound. But those are certainly not the only radioligands that are being developed. And this is an old list at this point, but you can see that there's many different binding motifs, linkers, alpha particles, beta particles, combination of those, whether you can sequence them or, if after you develop resistance to a beta particle, maybe you'll respond to an alpha particle. So these are all being studied mostly in phase 1 studies. So it's a very exciting time. Beyond that, there's also radioimmunoconjugates, and then of course, immunotherapy-based strategies in prostate cancer, which I unfortunately won't get into, but including bispecific antibodies, T-cell activating constructs, as well as ADCs. So I will close out with this phase 1 study that was just presented at ASCO. So this is looking at a new radioconjugate compound. So it's an alpha particle actinium labeled targeting HK2. It was presented by Dr. Morris. So HK2 is it's highly expressed on the membrane of prostate cancer. So in this case, it's actually a monoclonal antibody that's then conjugated to an alpha particle, which is different than a beta particle. It's a higher energy transfer and is thought to go a shorter distance, but potentially be more potent. So this study is a very complicated study design. So if you have questions about it, I would definitely say you should watch Dr. Morris's presentation. But it was a first in human phase 1 study, and there are multiple different they presented the escalation with fixed schedule dosing and then also the capped cumulative dose strategy. And it's still ongoing in terms of the adaptive dosing strategy is currently enrolling. And I believe UChicago is enrolling to this trial within the city. And as you can see, for a phase 1 study, this is looking at PSA response. So it did have a PSA response in this pretty heavily pretreated patient population, as well as you can see the swimmers plot. As we figured out the dosing, the patients were able to get higher and higher doses per the color there. So in conclusion, they were saying this is an exciting new compound. It's a very complicated study design because they were trying to figure out the toxicities and what's the correct dose. The side effects, again, we don't quite understand. So thrombocytopenia and then ILD was actually a pretty dose limiting toxicity. It seemed to be mitigated if you had a dose cap, but it's very, we asked him about this. This compound's not taken up in the lungs, so why is it causing ILD? We don't exactly know. That's why we need phase 1 studies to figure out the right dose and everything else. But this is just an example of this new type of class of drugs that's coming obviously to prostate cancer, but will be coming to other solid tumors as well. So in summary, the landscape of advanced disease treatment options is definitely changing as we move our best therapies earlier and earlier in different combinations. I think that this is very wonderful for patients, but I think it begs the question of what are we doing to the disease biology once we do progress? There's a role for genomic sequencing in all prostate cancer patients, germline and somatic. And while we are identifying targets, this is an area that really needs to be developed to make sure that we're benefiting all patients with prostate cancer. And radioligand therapies make friends with nuclear medicine. I love Dr. Zhu. She's the best. That's it. Oh, good moderator. Yeah, okay. I just took that out of the talk just because it's not quite ready for prime time, but I'm prepared for this question. So that's a big thing. We have an amazing biomarker with PSA. So that's a big thing is why do we need to develop other biomarkers? I think it's important again, because it gives you an idea of what you're doing to the androgen receptor and things like that. But there was a number of different studies looking at correlatives with particularly with the PSMA4 as well as the therapy trial at ASCO, which were very, very interesting looking at the burden of ctDNA. So basically the burden of ctDNA, I'm gonna kind of summarize what I gathered from these two, but patients do better if they have a lower ctDNA burden, actually, which doesn't really completely correlate with PSA, maybe it does. And also ctDNA burden is inversely correlated to PSMA expression on PET. So that's what I was kind of alluding to. I think that there's going to be a patient population that in this advanced setting that are going to have a high ctDNA burden, but a low PSMA PET expression for whom chemotherapy is still going to be recommended potentially rather than lutetium PSMA because of the disease biology. So I think that looking at that trajectory is going to be very interesting. And they were just looking at ctDNA burden. and this phenotype of responding to radioligand therapy, but they haven't even looked into the genomics yet. But it seems, I think it will be complementary. But again, that's been a big thing. And I think that's why it hasn't been developed, is because we do have PSA. And PSA is pretty good. I think you have to decide. Yeah, I think I've seen some where people will kind of make a probably Dr. Twaji has a really good one for bladder cancer that she refers to, where it kind of helps you make the decision. But I think it very much matters, because we don't know exactly what will make somebody respond to a second exposure to an androgen receptor pathway inhibitor versus not. They're thinking maybe it's ctDNA, or maybe what you find on ctDNA, but I think we can more carefully select. But that's why I like prostate cancer.
Um, Thank you again for the very wonderful talk, Risen. I really, really appreciate it. So I'm going to be introducing, last but not the least speaker, Dr. Karin Taraji. She is an assistant professor of medicine in Division of Hematology Oncology at UIC, and she is the program director of fellowship training. So that is not accurate. So she's also a Canadian friend. And if anything happens in America, I will be going back to Canada. I already have a Canadian plug. So her interest is in bladder cancer, and she will be talking to us about bladder cancer. Please welcome Dr. Taraji.
I should be talking about kidney cancer today, but I'm excited to talk about kidney cancer. Bladder cancer is my first love, but today I'll be talking about kidney cancer. Yeah, close seconds. So we're going to dive into some treatment paradigms, just an overview of where we are with RCC treatment, and a couple updates from some of the recent meetings that we've had. And yes, as Abiola mentioned, it says I'm the GU program director on the thing, but I'm the fellowship program director, and Dr. Morera, our wonderful urology colleague, is the director of our GU program. And we have a really wonderful team in GU oncology at UIC. And so to put it into context, for some of the things that we're going to be discussing, we're first going to dive into the adjuvant space for localized RCC, and then talk about where we are with the landscape of metastatic RCC. And so a question here is, a 76-year-old man with an 11-centimeter clear cell renal cell carcinoma with sarcomatoid features, positive lymph nodes, is status post-surgery. What is the recommended treatment? Would you offer this patient observation, ipilimumab, nivolumab, pembrolizumab for 1 year, pembrolizumab for 2 years, or belzutifan for 1 year? And so I won't put anyone through answering this, but the answer here is C, and we're going to dive into the data on this with some of the updates. And so we know that pembrolizumab is the only really is the best drug that we have right now in the adjuvant setting for clear cell RCC for patients with intermediate, high, and local regional clear cell RCC. And we'll talk about the data for that. So for those of you that don't commonly treat kidney cancer, this is just a reminder of some of the staging and the survivals that you see with different stages of RCC. So stage 1s are those smaller tumors limited to the kidney. 5-year survival is very good. So 95%. Some of those patients, if the tumor is small enough, can even just have ablations. They don't actually need surgery. If they're 4 centimeters or less, usually people can get away with partial nephrectomy. If they're larger, they might need their entire kidney taken out. Stage 2 are more than 7 centimeters. 5-year survival is 88%. Stage 3s, you're starting to invade into local structures, or you have regional lymph nodes. 5-year survival is 59%. And then stage 4s is anything more advanced than that. And for that, the traditional 5-year survival was 20%. But we're making a lot of headway in terms of where we are with survival with our new treatments in RCC. And so in terms of adjuvant therapy for RCC, if we're looking at our stage 2s, so tumor more than 7 centimeter, or stage 3s, if they're invading into local major veins or perinephric tissues, or you have positive lymph nodes like our patient in our vignette, you can see that there's a clear role for recommendation of adjuvant pembrolizumab. For stage 2s, if you have grade 4 tumors, and also if you have sarcomatoid features that might portray a more aggressive behavior. And then for the stage 3s, definitely, you should at least have the discussion of adjuvant pembrolizumab. And so this is based on the Keynote 564 trial. And this looked at pembrolizumab compared to placebo. We've had a lot of other trials in the adjuvant space, including Ipi/Nivo in the adjuvant space, other checkpoint inhibitors, including atezolizumab, nivolumab, and previously we had TKIs in the adjuvant space. But as you've seen from the guidelines, this is really the main data that we have for adjuvant treatment in RCC. Similar to how Dr. Razin mentioned for prostate cancer, we're kind of in a biomarker agnostic state. This is the same for RCC at this point in time, but I'm going to highlight some updates throughout my presentation. I think one of the themes from ASCO this year was biomarker data in RCC. And so in terms of the updates that we've had for disease-free survival for Keynote 564, on the right-hand side, you can see the disease-free survival was trending in the right direction at the 30-month follow-up with a hazard ratio of 0.63 for pembrolizumab versus placebo. So that was a difference of 78.3 versus 67.3 at 24 months. And then overall survival, I don't have the updated slide here, but at ASCO GU, actually, it did meet its overall survival endpoint. So the hazard ratio was 0.62, and that was really exciting because this is already something that we were recommending to patients. In terms of the safety results, I highlighted in the red box some of the things that I wanted to mention because I think this is really important when you're talking to patients. So if you look at patients that got pembrolizumab, up to 80% of patients had treatment-related side effects, of which 18% had grade 3 or 4 side effects. Again, 18% leading to treatment discontinuation. And of those, 8.8% were immune-mediated adverse events, with 7.6% requiring high-dose steroids. And so, if you're counseling a patient, you would say, 80% of patients might have some treatment side effect from this potentially like benign treatment that you're giving for a year, but up to 20% of patients have side effects leading to treatment discontinuation. And about almost 1 in 10 have really severe side effects where you're ending up needing to give them systemic steroids or other treatments. And so this is an older slide from ASCO GU in 2022. And so how long do we treat? Right now, the approval is for 1 year. How do you treat someone who recurs after an adjuvant immunotherapy? I think this is one of the issues that is across disease sites, because all of the metastatic treatments are not in this new era of adjuvant treatments. We don't really know the answer to that. Again, the OS is now significant, so that was an exciting update that we had this year. And then what biomarkers can we use to better tailor recommendations? Because we know that PD-L1 has not been a good biomarker to predict this in RCC. But I'll talk about one of the studies that was presented 2 weeks ago that has a lot of potential. And the FDA label is broad. We should be careful to not overextend the usage, as I showed you some of the toxicity, both financially and in terms of side effects for patients. So there are some good normograms when you are having that discussion with patients in terms of telling patients, what's your probability of early disease progression? So in the same patient with a 7-centimeter tumor, on the left-hand side, you have their probability of early disease progression if they have sarcomatoid features on the pathology at 16.9% versus if they did not have sarcomatoid features on the right-hand side, it would be 8.4%. So if the patient has sarcomatoid features, you might make a stronger case for suggesting immunotherapy. And so, we do have a disease-free survival and an overall survival benefit now, which has been very exciting. But again, almost 1 in 5 have grade 3, 4 side effects leading to treatment discontinuation. and 7.6% requiring high-dose steroids. Is this acceptable in the adjuvant setting? Although rare, some patients will require lifelong treatment for diabetes, adrenal insufficiency, thyroid disorders, and other. It does have significant costs and some significant morbidity, and a personalized discussion is absolutely necessary. Perhaps we should consider it for those at highest risk, so those with sarcomatoid, T4 tumors, M1, NED. And another really important point here is that this is only for clear cell RCC. So when you're seeing someone with anything but clear cell RCC, there's really not a lot of data in the adjuvant space. And this was one of the updates that we saw. I think this was one of, again, there wasn't really anything practice changing at ASCO this year in terms of RCC treatment, but in terms of the thing that the kidney cancer experts were most excited about, I think this was it. So they looked at KIM-1, which is kidney injury marker 1 biomarker analysis. And KIM-1 is a biomarker that's a circulating biomarker, and it's been studied in drug discovery for nephrotoxicity, but they're looking at it now as maybe a biomarker of immunotherapy response. And this was one of the main slides that was, I think people were excited about. So they showed for IM motion, which was adjuvant atezolizumab, which was actually a negative trial. They showed that patients that had a high baseline KIM-1 had improved disease-free survival with atezolizumab. They also found that people with high KIM-1 had worse disease, more aggressive disease as well at baseline. And so the conclusion for this talk was that KIM-1 is a novel prognostic and predictive biomarker in the adjuvant RCC space. They would like to see it more in prospective trials. So I think a lot of people are going to be looking at this prospectively in RCC trials to come. So diving into metastatic RCC. So I think RCC is a little bit easier landscape than some of the other tumors that we have. So kind of covered localized when it comes to medical oncology, and now we're in metastatic. And about a quarter of patients with RCC present with metastases at the time of initial diagnosis. And 30% of patients develop recurrent disease after treatment of localized disease and do require systemic therapy. And these are our first-line therapy options. So we look at risk criteria, so we have favorable risk and then poor intermediate risk. And then I'm going to talk briefly about another ASCO update of this very favorable criteria that we hadn't really talked about previously. And so for favorable risk patients, we have 3 IO-TKI options: axitinib, pembrolizumab, cabozantinib, nivolumab, and lenvatinib, pembrolizumab. And then for a poor or intermediate risk, we have the same 3 options in addition to ipilimumab and nivolumab. And all of these practice-changing first-line trials have been approved in the last few years. So at ESMO in 2017, that's when we had the CheckMate 214 for ipi-nivo. And then in 2019, we had all of the other IO-TKI regimens. So Acamro, which was the KEYNOTE-426 trial, Cabo-Nivo, CheckMate 9ER. And then in 2021, we had Lenva-Pembro based on the third trial. And this was one of the updates presented at ASCO by Dr. Zarba, and he described a very favorable risk subgroup, which were the following criteria. It was time from primary diagnosis to systemic therapy over 3 years, the absence of brain, liver, or bone metastases, and a very good performance status. And then they retrospectively looked at what treatment people got in this favorable and in this very favorable categories. And so in all favorable risk patients, there was no difference in 2-year overall survival between the treatment regimens. However, they did find that IO with TKI has superior outcomes compared to TKI in terms of objective response rate, treatment duration, and time to next therapy. And on the left-hand side, you can see the curve for survival for doublet IO, IO-TKI, or TKI alone. And then in the subgroup of very favorable risk disease, there was a worse 2-year overall survival and objective response rate in patients that got ipi-nivo compared to other regimens. And this suggests perhaps the importance of a VEGF inhibitor under treatment with this patient subset. Again, these were smaller numbers, retrospective data. So there was one comment at the session that perhaps there are still some patients in these categories that could benefit from IO-IO, and I'm going to cover just as a reminder, an example of the durable response that we see with these doublet immunotherapy regimens. So the comment was, it's kind of a bold statement to say that people in the favorable and very favorable shouldn't get doublet IO, because there probably is still a subset of patients that could have really long durable responses. And so you have to be careful when you're presenting retrospective data to make such a bold statement. So I do, agree with that. I think it's important that we take this data into context and maybe don't generalize it beyond what it suggests. So just as a reminder for Ipi/Nivo or Checkmate 214, at the 5-year update, we saw in the intermediate poor risk patients that the overall survival difference was a median overall survival of 47 months versus 26.6 months on the left-hand side. And then for PFS, it was 11.6 versus 8.3 months. 60% of patients on the Ipi/Nivo arm did require systemic steroids, and 4% required steroid-sparing agents, including infliximab, mycophenolic acid. So it is important that we consider, the toxicity that comes with these regimens as well. But this was data that was presented again last year at ASCO. We know that for patients that respond, the responses can be excellent and very durable. So if you're looking at the complete responders, so there's 59 patients here that were complete responders. A third are still on treatment. Up to half are off treatment and never received subsequent systemic therapy. And then 20% off treatment received subsequent systemic therapy. And so on the right-hand side of the table, you can see that the median time to response was 2.8 months. The duration of response in complete responders was not reached. And then also in partial responders, ongoing response was observed in 61% of patients with Ipi/Nivo, and the median duration of response was not reached. So when we're having the discussion, and deciding which regimen to use, we know that there can be that really durable response for the responders, that quote unquote cure for those stage 4 patients. But that has to be weighed with those numbers that I just mentioned about the toxicity that you see with Ipi/Nivo. In terms of some ACCREDITED updates for Keynote 426, this was an update presented at ASCO by Dr. Brian Rinne. And so they looked at biomarkers in Keynote 426, and they found that higher T-cell inflamed gene expression profile values were positively associated with clinical outcomes for Pembro/Axi, and then angiogenesis had a positive association with sunitinib. Again, as has been shown in other studies, PD-L1 was not associated with clinical outcomes for Pembro/Axi, and Pembro/Axi showed improved objective response rates versus sunitinib across molecular subtypes. And then within the Pembro/Axi arm, the objective response rate was highest in the immune proliferative subtype, and within the sunitinib arm, the objective response rate was highest in the angiogenic subtype. So again, this doesn't really change anything. We're just trying to find biomarkers to maybe predict, who needs these certain regimens versus others. How can we predict immunotherapy response in RCC? And then the other update that was presented 2 weeks ago was biomarkers in the CLEAR study. And Dr. Choueiri again looked at different biomarkers, and the PFS favored lenvatinib pembrolizumab across molecular subtypes. And there was no predictive role for PD-L1 gene mutations or RNA signatures, again highlighting the ongoing unmet need to uncover biomarkers for immunotherapy response in RCC. So in terms of where we are with current immunotherapy therapy, we know that we have high response rates, durable responses, effective combinations. We've had the best results to date in RCC. They're not really novel anymore at this point, the IO combinations, but we've had them around for a few years. Some patients still have primary progression. A lot of patients develop eventual progression. Not all patients maybe need immunotherapy, and most patients still die of RCC. And there's been a lot of these Me Too trials, all these IO-TKI regimens limited to immunotherapy. And this is a summary of where we are right now with, the frontline therapies. I'm not going to go into detail, but again, you're not comparing across trial, but this is kind of a good slide showing some of the features that we're seeing across these trials. So we have, many options to choose from with no head-to-head comparisons, but where is the future in terms of first-line therapies? So we have triplets and induction maintenance combos based on response. And this is a summary that I really like from last year at ASCO in terms of if you're going to put first-line RCC treatment in one slide, first ask yourself, is it oligometastatic, presented tumor board? And if there's amenable lesions to local therapies, that should be offered. So SBRT, resection, ablation. If they don't have oligometastatic disease, ask yourself, are there sarcomatoid features? Those patients should get IO. If they don't have sarcomatoid features, do they require rapid response? Do they have rapidly progressive disease, impending visceral crisis? If the answer is yes, you should offer them IO-TKI for that quick response. And then if no, you should aim for that durable response while counseling patients of that really high potential of immune-related adverse event, including some that could be, lifelong. And you can offer them ipi/nivo. In terms of next steps, we have some trials that are going to be reading out. So Cosmic 313 is looking at ipi/nivo with cabozantinib. MK6482 is looking at belzutifan with lenvatinib, pembrolizumab, and I'll talk about belzutifan in a minute. And then quavonlimab is a novel CTLA-4 being combined with pembro lenvatinib. And then the Pedigree trial, I think, is one that we're extremely excited to see read out soon. And so the Pedigree trial, actually, at the last Alliance meeting that we attended about a month ago, just announced that they finished accruing. So we're hoping to get results from this soon. And the trial design for this were patients with metastatic clear cell renal cell carcinoma, no prior systemic therapy. And they got the typical induction therapy if you're going to give someone ipi/nivo of the ipi one dosing with nivolumab 3 milligrams per kilogram. And then at 3 months, patients were assessed again with imaging. And then if they had a complete response, they went to the traditional treatment paradigm, which would be nivolumab every 4 weeks. And then if they had progression, they went to cabozantinib. But if they did not have complete response and if they did not have progression, so anyone with stable disease or a partial response was randomized to either nivolumab or nivolumab with cabozantinib. So kind of like a risk-adapted approach. So we're really excited to see the results of this come out, hopefully at a meeting soon, which will continue to change the paradigm of first-line RCC. So I did mention belzutifan. So we know that there is a role of HIF2 alpha in RCC. It's associated with angiogenesis, proliferation, metabolism, growth. And belzutifan is an oral potent selective small molecule HIF2 alpha inhibitor. And 90% of patients with sporadic clear cell RCC have defective VHL pathways. And so the LightSpark 003 was presented at ESMO. So there was a couple trials with belzutifan presented at ESMO this past October. And so it had 2 cohorts. The first one, cohort 1, is treatment naive patients that were given belzutifan with cabozantinib. And we saw in the treatment naive population that the overall response rate was 70%, of which 4 had a complete response. And then in cohort 2, these were patients with prior IO and also potential of possible TKI. They were given belzutifan with cabozantinib. And in those patients, the overall response rate was 31%. So in terms of where we are now for second-line systemic therapies, so the last time I updated this slide, belzutifan was actually in the useful in certain circumstances category. And then since the ESMO data, it's now moved into the recommended regimens. And then you can also see, otherwise you should give people a TKI that they haven't previously received. You can consider lenvatinib with the mTOR inhibitor everolimus. And then tivozanib, which I'll talk about in a few slides, is another novel TKI in this space. And then Contact 03, which was presented last summer, showed us that there is no role of rechallenging with immunotherapy in patients that receive prior immunotherapy. And so the question here was, if we add immunotherapy again versus TKI alone, does it improve the outcomes in patients previously treated with immunotherapy? And they found that adding atezolizumab to cabozantinib did not improve the response or progression-free survival versus cabozantinib alone. Also had higher grade 3-4 side effects. And so the response rate for cabozantinib by itself was about 40%. So it was effective. It had some good responses for immunotherapy refractory RCC. And in terms of belzutifan in the second line or more setting, we had the LightSpark 005 trial also presented at ESMO. And this is for patients that had received 1 to 3 prior systemic therapies, including at least 1 IO and 1 TKI. And they were randomized to belzutifan versus everolimus. And the progression-free survival and objective response rate was improved for belzutifan. The overall survival difference has not reached statistical significance. The final analysis is pending, and the quality of life metrics favored belzutifan. So at this point, we do have a role of belzutifan in the second line and beyond setting, but there's a lot of trials looking at it in the adjuvant space, in the first line setting, as well as in combination with other regimens, as I mentioned. In terms of third line and beyond therapy, there is not that much data. We have TiVo-3. The current clinical standard of care is to continue sequential therapy with approved agents until benefit no longer outweighs toxicities or the patient's performance status decline, and of course, to consider clinical trials. So tivozanib is a highly potent and selective VEGF receptor, which inhibits phosphorylation. It has a 4 to 5 day half-life, and 10-fold higher concentrations are required to inhibit c-KIT and platelet-derived growth factor. And compared to some of the earlier TKIs, it was designed to optimize VEGF blockade while minimizing off-target toxic effects, ultimately resulting in fewer dose interruptions and dose reductions. So it's approved right now in patients that have progressed after 2 or more prior systemic therapies, including at least 1 immunotherapy regimen. And this is based on the TiVo-3 trial. So again, they had, oh, sorry, not prior immunotherapy. They had to have failed 2 or 3 prior regimens, including at least 1 VEGF. But again, everyone is getting immunotherapy in the frontline setting, whether it's, so everyone pretty much in this day and age is getting immunotherapy. So they were randomized to tivozanib or sorafenib. And at 1 year, the PFS difference was 28 versus 11%. And at 2 years, it was 18 versus 5%. And this is highlighting some of the trials that we have for RCC right now at UIC. So we don't have anything in the localized setting right now, but in the metastatic setting, we have S1931, which is looking at cytoreductive nephrectomy for metastatic RCC in addition to systemic treatment. There's also been a lot of trials looking at radiation to the kidney. So we should have results from those trials in the years to come. And then we also have some phase 1 studies in RCC. And then we have the Stellar 002 that has an RCC arm with XL092, which is a novel TKI that also has a narrower therapeutic index than some of the other TKIs, with hopefully also less off-target side effects. And just to conclude, I'm just briefly going to talk about non-clear cell RCC. There was one update that was mentioned at ASCO. And so one of the problems with non-clear cell is if you're looking at NCCN and you're not a kidney cancer expert, this is, what you're referring to. And really, if you think of non-clear cell, there are so many different histologies and they're extremely heterogeneous. So thinking about chromophobe versus papillary versus RCC NOS, or these HLRCC, hereditary leiomyomatosis, or medullary renal carcinoma, they're all so incredibly different in terms of their biology, their mechanism, how they would respond to these treatments. So you really cannot refer to NCCN when you're thinking about a non-clear cell RCC. You really have to dive into the literature and see what's available, because otherwise you might be doing a disservice to the patient that you're seeing in front of you. So in terms of some of the regimens that we have, for patients with hereditary leiomyomatosis, you can do bevacizumab or lotinib. But otherwise, in terms of the other regimens, you kind of have to dig into what's one of the preferred options. There's been increasing data for IO TKI in these papillaries, papillary RCC, which would be the most common non-clear cell that we see. So that's one of the things that we've been using. And this was one update that was presented at ASCO for metastatic chromophobe RCC, which is quite rare. And based on retrospective data, it showed that combination therapies may be more efficacious. So if you look at the red line, those were TKI or mTOR, so everolimus alone. And the median overall survival was 23 months. And then if you look at the first purple line, it was TKI with mTOR. And so the median OS was 99 months. And then for IO TKI was 56 months. And then for IO was not reached. So the summary of this presentation was that we should be considering combination therapies for patients with metastatic chromophobe RCC. If you do see it, again, it's very rare. But it was good to see, you know, a lot of data presented at ASCO in the GU space, at least for some of these rare tumors. In addition to metastatic chromophobe, there was a presentation on adrenocortical carcinoma. There was one on penile cancer. So we're seeing more data on some of these tumors that we maybe don't see as commonly. So in conclusion, for adjuvant therapy, it's important to have a risk-benefit discussion. You know, the FDA label is broad, so it's important to consider, you know, the patient sitting in front of you and talking about the pros and cons of proceeding. In terms of the future of first-line therapy, I think we're going to see triplet combinations as well as these induction maintenance combos based on the response. So kind of a risk-adaptive approach of treatment. We definitely need more biomarkers. You know, we're not in the precision oncology era of RCC yet. You know, we've seen it in bladder cancer, but in kidney cancer, we still need more biomarkers to predict immunotherapy response. I think the update from ASCO was that KIM-1 was the most exciting biomarker that maybe we have right now, but we need more prospective data looking at KIM-1, and we need more trials looking at non-clear cell RCC treatment. And that's all. Thank you. Any questions?
But after there's a lot of exciting neoadjuvant treatment.
Yes, there have been quite a few neoadjuvant trials. I think they've looked, I know the Nadina trial for melanoma, they've done I think similar trial concepts in RCC. I don't think the toxicity has justified kind of the results that they've seen. There haven't been any positive trials, obviously, but there are a lot of people looking at this perioperative space of RCC treatment for sure. Yeah. Thank you. Yeah, thanks.